In that network meta-analysis, we showed you we have those three partial agonists, A, B, C, plus lorazepam as a president, that seem to be clustering together with very similar metabolic profile. But these are different agents. You know, we've got partial agonists here and dopamine antagonists. So there's something about their broader receptor pharmacology that can explain why they seem to be clustering together, at least when it comes to metabolic side effects. And that's what Rob did in this study. He looked at 27 antipsychotics and the receptor binding profiles across 42 different receptors. Again, we're talking about dopamine receptors, serotonergic receptors, muscarinic receptors, histaminic receptors, etc. He created a correlation matrix where he looked to see which drugs in the rows that you're showing on the left-hand side were similar to the drugs in the columns along the bottom here. And that's what's shown in this heat map here. If you looked across all of those receptor binding profiles, which treatments were most similar to other treatments based on their binding profiles across those 42 different receptors. And then we ran a clustering algorithm, which looked to group those treatments together in families that were most similar to each other with regards to their receptor binding profiles, with regards to their pharmacology. And as you can see in this heat map, the darker the red, the darker, the blacker the color, which is going through light, like white, all the way down through indigo to black, the darker the color, the more similar those treatments are to each other with regard to their pharmacology. And you can see that broadly speaking, four clusters have been defined. And then using a principal components analysis, Rob was able to define those clusters, those four clusters, based and work out what was their predominant receptor binding signature. And what was interesting is that for those four clusters, there were individual respective signatures. So for the first cluster, which included drugs like olanzapine, clozapine, quetiapine, we had a cluster that was typically defined by muscarinic and histaminergic antagonists. Then we had a second cluster, which had aripiprazole, brexpiprazole, cariprazine, lorazepam, and ziprasidone, which were characterized not only by the partial agonism of those three drugs, the ABC drugs, but also an adrenergic effects. And that's interesting because that's in line, and I just squared that for clarity, that's in line with the clustering that we'd already identified using our network meta-analysis. Then we had a third cluster, which had drugs like haloperidol and risperidone, which was broadly sort of dopaminergic and serotonergic in its activity. And then finally, we had a fourth cluster, which was quite purely dopaminergic, so amisulpride, sulpride, meside. And then, separate to this study, we had gathered side effect data across all of those different treatments that we had focused on in this study. And we were able to see what the typical side effect profile was of the drugs seen within those four clusters. And that's shown in this diagram here. So we've got the four clusters as four rows, cluster 1, cluster 2, cluster 3, cluster 4. And then we've got 13 key side effects that we're interested in looking at: raised prolactin, movement side effects, weight gain, raised lipids, broader metabolic side effects, anticholinergic side effects. The darker the squares are, the greater the magnitude or greater the risk of those side effects for those clusters. And rather unsurprisingly, I suppose, for cluster 1, remember those were antipsychotics, quetiapine, clozapine. You've got bad anticholinergic side effects, greater risk of anticholinergic side effects, but also greater risk of those metabolic side effects. For cluster 2, the partial agonists, ziprasidone, etc., actually relatively light side effect burden across the board. Cluster 3, again, this is risperidone, haloperidol, etc. You've got sort of the opposite to cluster 2, where you've got a sort of a broad side effect profile where a lot of different side effects are starting to rear their heads. But particularly, we're showing some movement side effects here, but you're also starting to get some problems with metabolic side effects. And then finally, for the purely dopaminergic side effects, it's not unsurprising here, you're starting to see those squares really light up for movement side effects and raised prolactin as well. So the key take-home message here is that, no surprises, you can start to explain the side effects of antipsychotics based on their pharmacology. But why do we care about this? Well, I think it's important to recognize this because it has implications on two parts for our clinical practice. Number one, if someone has a given side effect for a given treatment, then it would make sense, if you're in a position where you need to be switching treatment, then it makes sense to switch treatment to a different agent with a different pharmacology, so a different cluster essentially. So it can guide us with regards to choosing treatments where we're worried about side effects. But you can also argue that it can guide us when it comes to how effective our treatments are. If someone hasn't done well with a given antipsychotic, and when I say hasn't done well, I'd say there hasn't been adequate treatment response to that antipsychotic, then you would look to switch that treatment. There's no point in continuing ineffective treatment, but it doesn't make sense to switch that treatment pharmacologically to a drug within the same cluster. So they would argue that you'd be looking to switch to a different cluster in order to get a better side effect, to get better clinical response. Now, of course, it's all very well talking about clusters, but we live in the 21st century in the rather grandiose world of wanting to focus on not just clusters of drugs, but we want to focus on single agents. We want to know in a personalized manner which treatment is best for ourselves, for our patients, for our loved ones. We want to know the one drug that, all things being equal, we should be aiming to prescribe over others. And that is the topic of my this next section. I'm going to be describing a digital tool that very much facilitates that process. It's available at cymatic.com, and it facilitates evidence-based and personalized antipsychotic prescribing based on side effects. Before we reflect on Cymatic and what it is and how we designed it, I think it's important to take a step back and reflect on actually the thought process that people and clinicians go through when making prescription decisions. Because if I ask different colleagues how they go about deciding which antipsychotic to prescribe to a given patient, I get very different answers. So some people might say, well, I will just turn to the latest edition of the Morrissey prescribing guidelines. I'll be guided by that. Others will, depending on which country they're in, will say, well, I'll turn to my national guideline documents. So the UK use NICE, the APA has guidelines for America, etc. And they will be guided by those documents. And then there'll be other individuals who take matters into their own hands and will, fire up PubMed and look at the latest meta-analysis published by Steph and Lloyd and to guide the best treatments for their patient for a given symptom. If that's the case, and we want to do what our national guideline documents tell us to do, then let's have a moment and reflect on what these guidelines tell us. And I do apologise. I'm aware I'm talking to an international audience here, but I think certainly of the guideline documents that I've taken a look through, and I've looked through 19 now, they are similar when it comes to the sort of guidelines that they give. And I've put up here screenshots on the left from the UK NICE guidelines and on the right from the American Psychiatric Association guidelines for America. And when we talk about antipsychotic prescribing in the UK, if we forget clozapine in the context of treatment resistant, what's interesting is that the NICE guidelines don't name any antipsychotic specifically. Instead, they say if you're choosing an antipsychotic, you need to be ideally having an informed discussion with your patient about the benefits of treatment, but also about the potential side effects of treatment. And they list what you should be discussing. You should be having discussions about metabolic side effects, extrapyramidal side effects, cardiovascular side effects, hormonal side effects, and this rather nebulous other group of side effects. Now, if you were to obey these guidelines, and I predict the APA guidelines as well, it's very similar sort of guidance. If you are to obey these guidelines and say, okay, well, I'm going to have informed discusussions about the relative risk of different side effects with different treatments, then you need to be armed with the evidence. The problem is that for busy clinicians, indeed for anyone, there is so much evidence out there that is being published all the time. It is completely overwhelming to know which study to turn to. It doesn't seem like a day doesn't go by for another, I'm part of the problem here, I do recognize that, but another network meta-analysis published saying, no, forget the one that was published last week. these are the treatments that we need to be trying to prescribe preferentially over others. It becomes a bit of a mess. The other thing to bear in mind is that when we try and avoid one group of side effects, we can run the risk of increasing the risk of another group of side effects. And this was very much the situation that Odysseus found himself in when he was sailing back from the Battle of Troy all those years ago. There was a 10-year journey. He was sailing home to Ithaca, and on that journey, he encountered various perils. And this is a fresco painted, taken from an Italian fresco, and he's recognizing it's depicting one stage of this 10-year journey when Odysseus, who is this gentleman in his boat here, was sailing between two sea monsters. On the right-hand side, we have Charybdis, which is a sea monster that sat under a rock and swallowed lots of water, creating whirlpools that was trying to suck the boat down to a watery grave. And then on the other side, we had the sea monster called Scylla, a multi-headed monster that was plucking sailors from the deck of Odysseus's boat. Now, Odysseus was trying to sail a straight line between these two sea monsters. If he sailed too close to one monster, then he ran the risk of sailing too close to the other. And that is exactly where we find ourselves in as psychiatric practitioners, where we're sailing the good ship of efficacy. We're trying to choose the appropriate antipsychotic for our patient. For example, we're trying to avoid weight gain and sedation, but by doing so, we may be choosing antipsychotics that are increasing the risk of raised prolactin, extrapyramidal side effects, etc. It's a bit of a nightmare. So with that in mind, I'd be interested in getting your views. When you're choosing an antipsychotic with your patient and you're having that discussion as the clinical guideline documents tell you to, how long do you spend discussing potential side effects with your patients? Do you spend less than 5 minutes, between 5 and 15 minutes, between 15 and 30 minutes, 30 minutes to an hour, or more than an hour? Now, I love this question because when I've asked it online, I get very different answers to when I answer, usually very different answers to when I deliver this online to when I deliver the question in person. When it's in person, everyone's doing more than an hour. When it's online, people tend to be a little bit more honest. And there's an idiosyncrasy of my computer that I can't actually see the results. So I'm going to ask Joe if you can tell me what the results were. And I can see them now. Thank you much, Joe. They've appeared on my screen. Oh, fantastic. Half of people are saying between 5 and 15 minutes, and about 30% less than 5 minutes. I must say, this is actually this current audience are doing more discussing than a lot of the people that have answered this poll in the past. And usually, the less than 5 minutes is the winner. But most people are saying 5 to 15 minutes. Well, I'm afraid it is only the people who said 2%. Who said they would spend more than an hour who potentially right. Because actually, if you are obeying the clinical guideline documents, you need to be spending an awful lot of time with your patients to talk about side effects. If you want to compare 20 drugs based on one side effect, that's 190 pairwise comparisons. You want to do that for 10 side effects, that's 1,900 comparisons. If you spend 10 seconds discussing each of those comparisons, you'd need more than 5 hours of discussion. And of course, that gets even more difficult if you remember that some side effects will be more important to one patient than another, requiring a little bit more time spent on those. Essentially, what I'm getting at here, and I'm rather labouring the point, that what the clinical guideline documents are asking you to do is for you to be superhuman. Indeed, not only do you need to be superhuman, but the patient needs to be superhuman to remember all of that information. It's just impossible. But don't worry, because we have designed a solution to that, which was a description of this digital tool, Cymatic, was published a month ago now in the Lancet Psychiatry, and it was a sort of a two-part project which combined systematic review with digital tool development to support personalised and evidence-based prescribing. And we had two main goals. The first goal was that we wanted to address that issue of data overload. So we wanted to create a comprehensive database of psychotropic side effects, so we were focusing on both antipsychotics and antidepressants, where across common side effects, we had different relative risks or magnitudes for across all the different psychotics and antidepressants that were available for us to prescribe internationally. And then with that achieved, we wanted to address the issue of, having to spend 5 hours in one clinical consult when you come to talk about side effects, was to create a digital tool that allows you to navigate that database, take into account the concerns of different patients about side effects, and present, based on the patient concerns and the database, a personalized league table of treatments from best to worst that will best suit the patient. And the tool is called Cymatic. It is freely available, so you don't have to pay for it. You just need an email address. It can be any email address, doesn't have to be a clinical one. And it is available at www.cymatic.com. So how did we create the database? Well, first of all, we performed a systematic review. So we wanted to harvest all of that network meta-analytic data from randomized controlled trials in the monotherapy of schizophrenia. We also did monotherapy of antidepressants, but we're focused on schizophrenia here. And we looked at not only just acute treatment RCTs, but also longer-term sort of maintenance treatment RCTs, because we recognize that some side effects like tardive dyskinesia, venous thromboembolism, might occur not only in the first month of treatment, but a few months later. And not only did we harvest data from network meta-analyses, but we also harvested ordinal ranking data from clinical guideline documents from across the world. This is of the antipsychotic side effect database. So along the top, we've got 14 different side effects. On the left-hand side, we've got 32 antipsychotics. The hotter the square is, the greater the magnitude or the greater the risk of that given side effect for that given treatment. So, for example, the first column, Parkinsonism, shows that you can see that there's a very red square in the side, for example, and other red ones for Pixel, etc., Fluphenazine, whereas you've got other ones that are a lot lighter in colour. Use this database, you can print it out, stick it on the wall, and say, okay, well, I'm going to use this in my clinical practice, and I'm going to say, if someone's worried about practices, for example, I'm going to avoid those squares that are red, and I'm going to aim to use those treatments that are a lighter colour. But the problem is, it still doesn't, by doing that, you're still not addressing that issue that Odysseus had when he was sailing between the two sea monsters, where if you avoid one group of side effects, then you're increasing the risk of another, and that difficulty in personalising across treatments across various side effects. And so that's where Cymatic, the digital tool, comes into play. So if you navigate to cymatic.com and you log in with your email address, you'll be presented with a menu which allows you to choose which medication treatment optimizer you wish to use. And for the purposes of this talk, we're going to select the antipsychotic treatment optimizer. You click on that, and then you're presented with a drop-down menu that allows you to select which side effects you're most worried about, or your patient is most worried about. And in the case of this individual, my patient is most worried about weight gain. And there is a slider underneath that side effect from minor concern to major concern. So you can specify the relative degree of concern you have for one side effect compared to another. So now we've got we can add as many side effects as we like, and our patient is also worried about Parkinsonism. So we scroll down and select Parkinsonism as an option, but they aren't as worried about Parkinsonism as they are about weight gain, so they leave that concern slider in the middle. Then finally, they've got a third side effect, anticholinergic side effects that they want to avoid, but compared to the other side effects, this is of least concern. So they're dragging the slider, the relative degree of concern slider, over to the left. So we have 3 side effects at 3 different concern ratings, and then we click go. Now, before I show you the output, the key question for us is how do you combine that input on the left, the side effect concern ratings, with the database on the right? And we do that using something called multi-criteria decision-making, a statistical technique that we all use every day, I would argue, in our day-to-day lives. For example, if I wanted to take a winter break, I might need to choose between various holiday destinations. So I might have 3 different holiday destinations in mind. I might have beaches for Hawaii, the Gestard, the mountains of Gestard, or the clubs of Ibiza. Now, there may be three different aspects of a holiday destination that are important to me. I might want sun, good nightlife, and the place being child-friendly because I've got a 3-year-old at home. Now, of course, those different holiday destinations will have different pros and cons, benefits and negatives. So for those three aspects that are most important to me, Hawaii does very well for sun and being child-friendly. Maybe it's not so good for nightlife. Similarly, Ibiza, good for sun and nightlife, if you like that sort of thing, but not so child-friendly, you would argue. And you can draw a graph to decide which of those holiday destinations is closest to the perfect, the positive ideal solution, the best holiday destination. And we can draw a graph just looking at two criteria on their own for the moment, where we've got criteria 1, how sunny the place is, and criteria number 2, how child-friendly the place is. And of course, the green circle in the top right-hand corner is the most child-friendly and the most sunny holiday destination. And on that basis, Hawaii is doing pretty well. The negative ideal solution is completely the opposite. There's no sunshine and it's not child-friendly at all. So if we're only looking at two criteria, of course, Hawaii is doing better than the Swiss Alps and Ibiza. But if we had the third dimension, the fourth dimension, the fifth dimension, that might change. But of course, it's very difficult for our human brains to look at anything more than 3 dimensions. And that's when you start to need a computer to help you. And we can apply this principle to side effects of antipsychotics. So imagine that we are interested in avoiding 2 side effects, raised prolactin and sedation. In this case, we've flipped the axes around so that the negative ideal solution, the worst solution, is a drug at the top right-hand corner, the red circle, which is an antipsychotic that causes your prolactin to go through the roof and it sends you to sleep immediately. Whereas the green option in the bottom left-hand corner is no sedation and your prolactin is fine. So in this context, we've got 3 drugs, A, B, and C. Drug C might be a drug like amisulpride, for example, pretty bad for prolactin, usually, and because a bit of sedation in some people. Whereas drug A might be a drug like olanzapine, for example, where, very sedating, but maybe not so bad as prolactin. And in this context, you might decide that actually drug B is that Goldilocks drug, that sweet spot of which treatment we should be using preferentially. But again, as I said before, it's all right doing that for 2 criteria, but when you start doing over 3, 4, 5, etc. dimensions, it becomes a bit more complicated. But that's exactly what Cymatic does. It uses that multi-criteria decision-making to combine those 3 side effects at 3 concern ratings with the side effect database to create a personalized league table, which is shown as a heat map on the right-hand side here. And I'm going to zoom in on that heat map. What we can see here is a heat map with various columns. And I want you to focus, first of all, on the first column from left to right, so the overall column. The overall column it dictates the order of drugs from top to bottom, and it is the multi-criteria decision-informed statistical outcome of combining those 3 side effects, weight-gain hypothesis and anticholinergic side effects, at the different ratings with the side effect database. And it tells you which treatments are best, the lighter colours, compared to the worst, the darker colours, for those 3 side effects. So in the context of those 3 side effects I have mentioned, the drugs up here that are better than the others, the functional agonists, the trazodone, the irazodone, and the drugs at the bottom are, no surprises, drugs like olanzapine, possibly etc. So we've got the first column there, and then we've got the subsequent columns show the unweighted side effect magnitude for the different treatments taken directly from the side effect database. And then we've got an efficacy column as well, but that's not included in the algorithm. This part of the talk is that we now have a huge evidence-based psychotropic side effect database for people to use. It is, to the best of our knowledge, the largest that's ever been created. And then to allow us to navigate that, we've got a tool called Cymatic, which really does make you superhuman. In a fraction of a second, it allows you, if you were doing antidepressants and antipsychotics, to perform around 11,000 pairwise drug side effect comparisons. And by doing so, this is a tool that actually finally, for once, allows you to do what the clinical guideline documents have been asking you to do for so many years. It allows you to be evidence-based. It allows you to engage in multi-dimensional decision-making. But most importantly, it allows you to engage in shared decision-making with your patient. You can show your patients what you can hear your patients and take on board what their concerns and filter that in a clear way into the algorithm and come up with a selection of treatments that may suit them or more likely to suit them better than others. And in that context, we're very excited about this because it does really promise to improve a whole host of psychosocial and physiological outcomes. So we've talked about the impacts of antipsychotic side effects. We've talked about receptor binding profiles of these treatments. We've talked about cymatic. And I'd like to finish with a case. So, Catherine, 23-year-old female at university, but she was taken to A&E by her parents. And they say for the last 4 months or so, she's been, her GP has been, her family doctor has been treating her for depression. But nothing has seen, if anything, she's got worse over the last few weeks, getting more and more withdrawn, not leaving her room. Stopped eating and drinking, becoming paranoid, thinking that her parents had poisoned her food, she's destroyed her phone, she's worried about the television, monitoring her, she's been responding and talking to herself. She doesn't think there's a problem and didn't want to come into hospital and so or receive treatment. So eventually she was brought into treatment. The decision was made for her by clinicians in the accident and emergency department. Now, on the ward, Catherine's been prescribed risperidone up to 3 milligrams once daily. And after about 3 weeks, those psychotic symptoms, the paranoia, the persecuted delusions, the ideas of reference, have melted away to an extent where she's able to be discharged home. So that's good news. You see her now in a clinic, in an outpatient clinic, community, 2 months later. And the good news is that she's not presenting with positive symptoms of psychosis, so she isn't paranoid per se or reporting any of those previous positive symptoms. But what her mum tells you is that really she's not doing very much at all with herself. She's just sitting in front of the TV, doesn't go out. And you notice, you can see that she's put on weight. And also, on asking her, she also tells you that her periods stopped. And she had some bloods done recently, which shows that the prolactin levels are raised. Now, the question I've got for you guys is what would you do next? And actually, there are only 5 options that we've got here, because I would hope no one would do nothing. So we've got 5 options. First is to reduce the dose of risperidone, or you can add aripiprazole alongside the risperidone, a low dose, or you can decide to switch risperidone to something else. You can switch to aripiprazole, you can switch to olanzapine, or you can switch to cariprazine. Now again, I'm going to have to ask Joe to show me the results in a few seconds when they come up, and I do appreciate that some might argue that there's more than one right answer here, which is of course the case. I'd say that some answers are probably more right than others. So are you happy to show me the results? Yes. I can see them on the screen. Yeah, I can see them. You can see them. So let's run through them. So some people, 15% of people said they reduced the dose of risperidone. Now, if you remember the slide I showed you, I think she's on 3 milligrams of risperidone. I appreciate she's got first episode psychosis. But remember, I think we have a narrow therapeutic window here, and actually the amount of risperidone that's washing around in her body that's responsible for raised prolactin is actually going to be a small amount compared to the amount that's required to give therapeutic benefit in terms of the psychotic symptoms. So although you could give it a go, reducing the dose of risperidone, I would probably argue that that would be lower on my in my decision algorithm in terms of what I would do. Because I think it's less likely, it's not likely to work, and so you run a risk of relapse, I suppose. The majority of people, it's a bit of a tie actually, is augmenting of risperidone with aripiprazole or switching directly to aripiprazole. Someone said they switched to olanzapine. Well, that might help with the raised prolactin, but remember she's put on 4 kilograms of weight, so I'm not sure adding olanzapine in is going to be necessarily going to help that. And then the fifth of people switching sparingly. Now, I'm afraid that you're already okay to be a complete meanie about this. But the correct answer, actually, and I should have maybe put this down as an other option, is of course to use the cymatic antipsychotic treatment optimizing. But I am biased in this. Now, because we can use this very elegantly, I would argue for this patient, this case in point, where we have 2 side effects of concern. We've got weight gain and we've got symptoms of raised prolactin, so the hyperprolactinemia which is symptomatic. And for our patient, weight gain is very important. They don't want to put on weight, but actually it's the period stopping which is a real worry for them. And if we click go, then this is the result that cymatic tells us based on the concerns of the patient, but also the data that is available. And if we chose to switch, and if we can argue whether augmentation or switching is a better option, I think you can argue it both ways, and some might argue when you augment, and then if that's effective, then you want to switch further down the line. But if we play the game and we say, okay, well, we're looking to switch, maybe Catherine, the patient herself, says, look, I don't want to take this treatment that is causing these side effects. Then cymatic tells us, based on the available randomized control data we've got and the patient's concerns, that the drugs up based on weight gain, raised prolactin, drugs up here at the top are better than those drugs down here at the bottom: aripiprazole, ziprasidone, cariprazine, brexpiprazole, and olanzapine. And so some of you said switch to aripiprazole, reasonable option. The other thing to bear in mind, though, in the case of Catherine, is that she's obviously got negative symptoms. She's not doing anything. She's sitting in front of the TV, she's not really talking very much. And I think it is important, the back of that, and we recognise this, that actually, if we're thinking about negative symptoms, cariprazine is the only antipsychotic which has end-to-end trial data that shows superior efficacy when it comes to managing negative symptoms in patients with predominant negative syndrome. And that was shown in a Lancet paper in 2017, published by Nemeth and colleagues. So not only improving the negative symptoms, but improving people. But I agree with you. I think we need to be thinking about partial agonism, maybe cariprazine in the context of negative symptoms, but either switching or augmentation is a reasonable option. I'm going to finish there. I encourage everyone to use cymatic and let me know what you think. It is very much something that we're keen to get feedback on, or if there are other digital tools that you guys think might be helpful in day-to-day clinical practice. We are here to learn from you, and I will open up for any questions. Thank you very much indeed for your time. Thank you very much indeed. An excellent across and a most wonderful and comprehensive review of the side effects of antipsychotics, mechanisms, consequences, and solutions. And I think we will go straight to questions and see if you can help answer some of them. So let's have a look. Okay. Let's see where we are. Shaker with Mandela. So if the prolactin level is raised to around 1,000, what is the risk of inducing breast cancer compared to prolactin level of 2,500? No one knows, I'm afraid. Like I said before, the Yari-Tohonen paper is an indirect association between prolactin increasing antipsychotics and breast cancer risk, rather than actually looking at directly prolactin levels themselves. So I'm afraid we don't know. It is simply the presence of raised prolactin that seems to be is as deep, as granular as we can get with the data.
This is a question from Eleanor DiBiase. She's asking, would you consider a new function for synaptic tool to improve the tapering off, withdrawal of antipsychotic medication?
Sorry, with tapering?
Yes.
I've just got someone. Excuse me, sir. I'm in the middle of a talk. Yeah, thank you. I do apologise. Yeah, I think there's the option of tapering, and I think I'm very interested in this as a field. So we've got David Taylor's new tapering book that's come out, Horsley Guidelines. I think when it comes to antipsychotic tapering, it gets a bit, I think we're still understanding how to do it appropriately for different individuals. And so I would argue that at the moment, we need more data to enable to inform our practice. And so I don't think we're necessarily at a stage yet where we create a digital tool, but as soon as that data does become available, we can give people guidance on doses and how to safely reduce levels.
Another question here, a very interesting question. How do LAIs compare in terms of metabolic effects and mortality?
Great question. So the studies that have been published, so I'll answer that in two parts. In terms of efficacy, mortality generally, and then in terms of metabolic side effects. So metabolic side effects, the LAI drugs that we have available seem to have exactly the data we have the data available on, have exactly the same side effects regardless of how they're given. Essentially, it doesn't matter if they give them orally or give them as a long-acting injectable. In the clinical trial data that we've got, you get a similar magnitude of metabolic change. So, for example, we have aripiprazole oral data, aripiprazole long-acting injectable data, risperidone, etc. It's the same magnitude of weight. When it comes to cardiovascular outcomes and efficacy, it is recognised that long-acting injectable, when it comes to efficacy, long-acting treatments seem to be more efficacious than oral treatments. And we have that data from Yara Tahonen's group again, looking at real-world data in terms of rehospitalization rates in people with schizophrenia who are prescribed different types of antipsychotics. And it's the treatments that are given as a long-acting injectable and clozapine that actually have fewer hospital admissions compared to other treatments. Now, what does that tell me? It tells me that you need to take your treatment for it to be effective, obviously. And we know that these antipsychotics are all effective, but you have to take them. And the reason why if you have an injectable agent, there's no way of getting away from taking that. If you're thinking about oral agents, then you need to have a treatment. This is coming back to my issue about side effects. If someone has side effects, they're not going to want to take their treatment. And so you need to be thinking about, okay, well, we need to identify and find treatments that are better suited to individuals. And that's where, using something like synaptic is helpful. And then you could make the argument that if you're really worried you can't use an injectable agent, but you want to use a long-acting formulation, then actually drugs like aripiprazole and cariprazine, which have actually quite long half-lives, are almost like an oral depot in some ways, which can be helpful in that context. So actually, you wouldn't want to tell your patient necessarily this, it doesn't matter if you miss the one dose here or there, the plasma levels will sort of stay there. So, and then when it comes to mortality data, I don't know off the top of my head if anyone's looked at the difference between injectable agents and oral agents, but we do know, just as a class effect, antipsychotics are associated with better mortality outcomes. And actually the best one is for clozapine, which is an oral agent in its own right, which is an interesting outcome when you consider the metabolic side effects of clozapine, of course. But it really does serve to demonstrate this sort of weird seesaw of balancing effect, side effect, but recognizing that these treatments are effective and help people live longer lives. We just want to make them even better by choosing the most appropriate treatments where possible.
Let's see,